What a terrible existence to be the prisoner of other people's thoughts of you. That
Mm.
is what really made me very mad is what if I look back in 10 years and think, oh, I never made content because I was too worried about what other people would think of me.
Welcome back to the Med Story Podcast. I'm Spencer Locke, your host, and this is a really good conversation. We sit down with Dr. Kazarian, who just recently finished her residency and now going into full-time practice. In this episode, we are going to learn about the toxicity that we find in the residency culture, the challenges that we see within the healthcare system as a whole, and how she is trying to break free of that by educating the public with the quality information that the doctors have behind closed doors. It's a great conversation. I think you're really going to enjoy it. So let's get into it. We're going to have a lot of fun here. So let's dive right into this. If we were to go to the top of a rooftop and you were to scream something to the world that they need to hear about our healthcare system, what is that thing that they need to hear?
People over money. People over money.
Oh, I love that. Tell me, why do you say that?
Because it's multifaceted throughout the whole healthcare system is we run into multiple problems where it's always, the bottom line is always money, saving money. And it is shown in many different ways, the cost of medications in the United States, the cost of staying at a hospital, the cost of health insurance, getting denied care, life-saving care. People in America get denied chemo. We can get into that later.
So at what point did you realize that this was a problem? And did you know this was a problem before even going into medicine yourself?
I guess my answer is a privileged one, meaning that not really. I was on my parents' health insurance until I was 26 and then was in medical school and residency being a job. So as a resident, you get health insurance and it comes out of your paycheck. So you don't really think about it. There's not a lot of time to think about much in residency, but then working as a doctor, your first year as an intern is really when it hits you. You can see how much money it costs to stay for one of your patients in the chart. And they'll stay for something very straightforward that they needed to be there for. And the bill that gets sent to insurance is tens of thousands of dollars, if not over hundreds of thousands of dollars.
Can you think of a specific time where you came to that realization, like with a specific patient?
It was it was a patient that I had actually admitted overnight myself, who I had then escalated to ICU care and then received again 2 weeks later when they were stabilized out of the ICU back to the floor and I was still working as a resident. And you go off service and then you come back 2 weeks later and the patient that you originally admitted is there. You can't help but think, what are all the things that this person has gone through? So I started reading the hospital course of everything that happened in the ICU. Think about all of the specialty teams that need to be involved, and then also all the allied health professions that are involved, including physical therapy and occupational therapy and speech language pathology and all of the amazing people that work in the hospital. All of those things add up. And then there's always fees that the hospital applies to the services that you get. On top of the services that the professionals are doing and getting paid for, the hospital is always making money every turn of the way. There's always hospital fees for everything. And that's why things come out and are so expensive. There's an inflation to healthcare services in America because it's just hospitals are for-profit corporations in America.
But the challenge is that even hospitals themselves, they operate off of very thin profit margins, but they do it at scale. And so at what point does the business of healthcare translate down into how you treat patients?
I think it trickles down and affects all of us. Healthcare can be very grueling because you take care of patients and there's no structured time for grief or recovery after having, created rapport with a patient and potentially losing them when you're working in a hospital. So there's a lot of stress. And when you work long hours and you also don't feel either appreciated for your work on the job or you don't feel appreciated in your paycheck. For example, I think nurses are sorely underpaid. I think it's terrible. We can also talk about that, but I think that tensions arise between healthcare team members when everyone has their own story and everyone should be getting paid more and more appreciated. And then it turns into interpersonal stress among teams and hospitals, I think, when the problem, comes from above.
For sure. And I think it's been cultural almost. It's been built
Yeah.
into the culture. And I think almost a one place to point at where that toxicity lives on may be in the culture of residency. You are someone that just went through residency and you alluded to saying how there's not much free time. Can you explain to me what that process is, especially as you had just finished it?
I'm looking forward to see what the real world job is going to be like, but residency, you don't really know. People will tell you that it's gonna be one of the hardest times in your life, but you don't really know what it is, what it's like until you go through it yourself, and it really feels like a marathon, and so you are excited and you wanna start the marathon because you're there to get training and you're so excited about your training. It's what you've been taking all these exams for, it's what you've been waiting for. But then when you're in the middle of it, it's really easy to get lost in the sauce because you're going day in and day out. I remember being on inpatient pediatric hospital medicine, and I think I had worked 15 days in a row. You don't even it doesn't matter what day of the week it is. You just know that when sign out is and when you have to be there the next morning, when you're working 12-hour shifts that turn into 13, 14 hours because of things you need to wrap up for patients at the end of your shift, and you can't go home and just leave it with someone else. Or you have back-to-back admissions that make you stay longer because now you have all of this paperwork and documentation that you also have to complete. It was a very long it just felt like a psychological, emotional, physical marathon. And you're also taking exams. You have to pass in training exams once a year. You have to do the USMLE step 3 in residency, and then I also took my specialty boards in family medicine before I graduated residency as well. So,
Wow.
yeah, 80 hours a week is totally normal.
Why do you think that
Or
is?
yeah. It starts with the conception of residency training. The history of it is that residents actually were living at the hospital, and I don't know the name of the guy. This is now coming up for a second time, so I need to learn this guy's name, but he stayed awake by doing cocaine and sleeping by taking heroin. That was the way they used to do it back then. Now we're talking the 1800s. And so it just comes from this really toxic culture of prestige and hierarchy, and the more time you put in, the more respect you get, and the person who works the hardest and has the most trophies or medals when academically is the best. That's the attitude. And yeah, I left academics for now. And here's what I love about academics is the amount of amazing people it brings together. Everybody's so highly trained. People have combined decades and decades of in so many different things inside of a hospital. And the teaching is amazing. How you gradually go from PGY 1 to 2 to 3 and you learn so much and then you pass down that knowledge. That process is so beautiful. I love academic medicine in that way. But the hierarchy of academic medicine is something that I think I needed a little bit of a break from. And so that's why I'm going into private practice for now.
Do you think it's almost passing the baton on? Because it's almost like this very challenging cycle where you're like, I went through this. So that means that the
Oh,
people
yeah.
after me should also go through this.
Yeah. I remember to an attending after working a night shift in the morning when they came on and they were like, "You don't look too good." I was like, "Yeah, I don't feel too good." They asked why, and I said, "I'm on my 6th 24-hour shift of the year," which was, I think I had to do cover for someone else, so I ended up doing 7 or something, but yeah, so it was supposed to be my last one, and I told them how hard that was, and then she said, "Dang, I" they said, "Oh, back in my day, we had to do 14 of those, and so this is nothing," and that just missed the mark. It completely missed the mark.
Mm.
And I think not because they were trying to be not understanding, I just think that culture and that mindset of, "I had it worse, this is not a big deal," is really ingrained in people in medicine, very much.
At what point do we stop that cycle and how do we stop it?
I think by talking about it like this, I think by being vocal residents, I think I was a very vocal resident, which stirs a lot of other people's opinions but I think that we need to start talking about it. And I think that with generations coming, you would hope I hear my generation talking about it way more than the older physicians. So you would hope as we age and become attendings, that's what we carry forward. And I see other attendings posting on social media a lot of advocacy for resident wellness. When residents have finished working and they're on their they've been on service for 2 weeks and they have the opportunity to go home a little earlier, attendings should let people go home a little bit earlier. Or if you need more sick days for whatever reason, your program should be working with you and not making you make it up later. Also, yeah, we could talk about also just the resident pay in general, which I think is antiquated and has not risen with the rise of inflation at all. Actually, is the resident pay is mostly made up of Medicare dollars with a little bit of money coming from the hospital, but we don't get, I guess what we're worth. The hospital keeps most of that Medicare money.
Hmm.
So, yeah, that's also a profit margin that hospitals take I was saying people over money. What if we paid residents more and made them feel more appreciated? Would they be happier on the job? Would they have more resources that takes a strain away from other places, such as a lot of people in residency are in their 30s and 40s. People have kids, and childcare in America is expensive, and healthcare is expensive, and food is expensive. So if we could just pay residents what they're worth, I think that would be a major step forward, and that could just come from Medicare dollars and reallocating it away from the hospital and giving it a little bit more to residents, which I would love to see whoever is lobbying for that.
I know there are people that are for sure lobbying
Yeah,
for
I know
that.
there are too.
And it's actually interesting. So I think that there along this cycle, there are a lot of things to consider. And when we first start with it, it comes down to the cost of school and the amount of debt
Mhm.
that doctors have to go into. And that cycle to be like spending what, $250,000 on school, then waiting a long time before they actually start making a real salary,
Yeah.
finally getting out and then having to do it. Like that's a very broken system.
Yeah, and then how do I tell that med student to go into primary care, which makes the least amount of money? How do I do that now? And how do I tell that med student to go into primary care now that they capped the amount of money that med students or graduate students in general can just take out? In the new One Big Beautiful Bill, HR1 bill, they capped the amount of money that you can take out for federal graduate loans at $200,000, which isn't what medical school costs. Med school costs way more than that. If you're out of state going to medical school, which a lot of people are because it's hard to get into medical school, then I know people who have spent $400,000 to go to out of state top medical school. So, yeah, we are driving med students and other grad students towards for-profit lenders that can charge whatever predatory interest rates they want.
Yeah,
Because the maximum amount you can take out from the government is now 200, which is so 50,000 a year.
right.
And where else are you gonna get the money from if you're not already rich?
Yeah, absolutely,
So,
for sure. And
yeah.
like we have to ask ourselves as the public is, do we want our doctors, the one that are guiding our care, to have this added stressor that they're worrying about in the back of their head to say, I need to pay off all these loans and maybe not be fully present there for the patient. And
Yeah.
you're seeing that even so with your case, because you're going into family medicine private
Mhm.
practice, and
Mhm.
there's going to be some standard that you need to start seeing a certain amount of patients so that the
Mhm.
clinic can make money as well. Can
Yeah,
you break
absolutely.
down what that looks like?
Yeah. So, private practices need to hash out deals with the payers, the insurance companies, on an individual basis. So that's why it's hard for primary care solo practices to even exist. It's because you have to get reimbursed. And insurance companies for the same thing do not reimburse solo practices at the rate that they reimburse hospitals. And that's why a lot of doctors find a lot of safety and security in working for hospitals because they know the reimbursement at the hospital level is pretty standardized, whereas we're all fighting for ourselves for reimbursement on the community level. And in order to get reimbursed, the insurance company tells us you have to see a certain amount of patients in order to get reimbursed. And that goes into billing and coding, but doctors can bill a level 2, 3, 4, 5, or based on time. And we all have to negotiate what is a level 4 worth? What is a level 3 worth? How much work do I have to prove through documentation that I'll get reimbursed for level 4? And most of the time you get reimbursed even like less than what the deal was. You get reimbursed at 75%. So in order to meet certain quotas, I have to see a certain amount of patients every day. That means that my follow-up visits with you are 15 minutes and my initial visit with you is 45 minutes. That's what my practice has it set at. My
Oh,
so the first time I meet you, I get to talk to you for 45 minutes, and then you get an annual with me once a year that is also 45 minutes. But then if there's anything that you want to talk about in between, it's 15 minutes.
wow. Yeah.
And I think that I have it pretty good because I I interviewed at a lot of places after residency for primary care jobs, and this is why you can't just throw a blanket over primary care because all of the jobs are so different. They all look so different from one another. You can get a contract for $280,000, $300,000 a year, but you're seeing 22 patients every single day. That's all 15-minute slots, and goals are maybe like 20 minutes, 25 minutes. Or you can take a more laid back job and I'm trying to see 16 to 18 patients a day. If it's quick sick visits, then I could see myself pushing up to 20, but that's my goal, is to live around 16, 18 patients a day, and I don't need that extra to 22. That kind of life does not sound fun to me.
I think it's wise of you to start thinking about these things because your career is just starting and you want a long and prosperous career. You don't want to just burn yourself out, which a lot of providers are doing. And that's the
Mhm.
scary thing, is that people are burning out. They're leaving the profession. And then that's going to leave a massive gap
I
for the demand of care and the people that provide it.
Yeah.
So I know this is something that you've gotten really passionate about and you've taken to social media. You started to create content. Why? Why did you do that?
So I think that there are a lot of influencers on social media, and what we need are experts on social media. There are amazing conversations that are happening behind closed doors in clinics between physicians and nurse practitioners, physicians, associates, with their patients. And what if with the things that we just say all the time to our patients and with the things that we teach our patients all the time, why can't we take those things and put them on a larger scale? And you just got to feel comfortable in front of a camera at home alone. Honestly, you just make a couple of videos at first and then it's normal, and then you just get over it. And if there's any doctors listening or any healthcare people listening, I want you to be on social media. And you just take a dive and you start echoing the messages that are happening behind closed doors. And then that will benefit hundreds of people, hopefully, if not thousands, or at least, a couple more people than just the one person in clinic that you saw. And we're in an era of misinformation. And so that's why doctors need to be spreading education on social media. And I've built a great community. I've met so many doctors and so many other healthcare professionals on social media. And now my entire social media is educational. It's great.
I love to hear you say that. It's literally why I started MedStory, is I realized all of the BS that was out there by these influencers who didn't actually know what they were talking about, which was
Yeah.
being really dangerous. It's like we need our physicians to start getting out there and our other providers, but they need to figure out how to do it. Like we need to find ways to lift them up so this process becomes as easy as possible to put quality information out into the world. And so for you, when you started making your first video, was there some apprehension with it?
Oh, absolutely, because I was in residency and there's such a large physician community on social media, and as a resident, you want to say the things that you know, but you know that other people know so much more than you and you're worried you're gonna say something wrong. But if anything, it actually helped me read more and learn more. Before I say this, let me just double check that. And then you compound on that knowledge, and then the next time you're talking about something, even at on the job, then it's just like learning on the job in the hospital when you make educational content. And you gotta get over what do I look like? How do I sound? Just present yourself the way you would otherwise present yourself well and just speak and see what happens. And you just have to make something exist, and then later you make it perfect. You can't start off being perfect, and we're all such type A perfectionists so that we're very uncomfortable being new at something because we like being really good at what we do. But I see it as a really fun hobby now, and I'm really glad I made the jump and stopped caring about there's this cringe culture that I hate. I hate it so much. It's this fear of being creative and expressing yourself beyond what everyone else thinks of you, and being worried that people think that is cringy. And terrible existence to be the prisoner of other people's thoughts of you. That
Mm.
is what really made me very mad is what if I look back in 10 years and think, "Oh, I never made content because I was too worried about what other people would think of me." And that made me it just gave me a little bit of anger, and I thought, "No, that's not what that we can't have that."
It's probably the number one reason that people stay away from it because they are measuring their success based off of likes, which is the
Mm,
last thing that you want to do,
yeah,
right? Because even if that video gets out there and it's seen by one person that can get educated or it changes their life in a small way, then that
mhm.
video is worth being created.
I totally agree.
Yeah.
Totally. And one thing that I also learned to do was separate my Instagram or my TikTok with my ego, and rather I attached it to the message that I want to deliver, and so my message is primary care education and talking about the US healthcare landscape. Those are the 2 things that I mainly talk about. I talk a lot about obesity medicine too. And so if I'm focused on the number of likes that a video is getting or the number of views, then that's speaking to my validation or my ego. I'm just happy, look at that amazing video that I made because it talks about birth control for PCOS, and someone else maybe was never offered that for their PCOS, and that is the only thing that actually matters. Yeah.
Now, this is because someone's going to listen to this and be like, yeah, but you have had a video go viral at this point. I have
Yeah.
not. You went along, you were making it. The first few, I'm sure, didn't pick off, but then you had that one video that probably did really well. Can you
Yeah.
tell me about that process? What happened?
Yeah, so, of course, you're making videos and it's not getting a lot of attention, and that's not gonna feel amazing, but you just gotta keep going and stay true to what it is you feel passionate about saying, because the first video that I made that went viral, I think now has over 4,000,000 views and just so many likes and comments. I made that video after a shift in my car, angry about I was thankful for how amazing all of my procedures had gone that day, but how terrible I have heard all of those women say their prior experiences getting IUD insertion were, and how unnecessary all that pain was, and that the things that I did today weren't that super complicated or exemplary. They're just things that you need to do to provide numbing, and that is just basic for me, and so I was just thinking about, why does it have to be this way? And I had a message to say, and I recorded it in my car, and then I posted it, and then it went viral, and I didn't think that video was gonna go viral. I thought it was just gonna be another video, and you seriously never know what's gonna ring a bell with people and what's gonna pick up and get shoot off on the algorithm. I don't think you can predict it. I think it's like gambling.
You can't. And that's the challenge because there's a lot of people on here saying, here's how you go viral. Here's how you go viral. But what happens often or most times in my experience is that the more time you spend on a video and like overthinking it and producing it, actually the less likely it can be to actually go viral. And
Yeah.
there's times where you'll be like, I'm just going to try this one and it does really well. And you would never be able to guess that.
Yeah.
And that uncertainty is almost like you just got to put it out there and see what happens.
You know what's weird?
Hmm.
All of my viral videos are me in the car.
Maybe you're
I'm
onto
in
something.
I'm just in the car talking to myself, and I'm just decompressing after my day and talking about the bullshit.
Yeah,
Yeah.
yeah. But it's that like raw organic nature
Yeah,
that I think people are craving nowadays.
I think so too. I think so too. Yeah.
Yeah.
It's how connection is through narrative and patient
Yes.
stories and
Yes.
honing in on one example that has a broader application in the end, stuff like that. I think that people really connect with that.
I love that. Okay. So tell me, let's look now to the future as you start your first job as an attending, as a primary care doctor, and continue to educate the public. Where do you want to be 5 years from now?
I wanna add the obesity medicine board certification, which I'm taking this October, and I wanna be a practicing obesity doctor and family doctor. I never wanna lose my passion for women's health. Whether I'm still at a brick and mortar private practice or I think that the direct primary care model is amazing, and I have a lot of qualms with the way that healthcare is structured and the way that insurance companies, how much power they have at this time. I think that the DPC model could be a solution for a lot of people. We just have to make sure that we make it accessible through cost as well, or else we're also the culprit if we're going to turn DPC into just for profit type of thing. Whereas I think DPC speaks more to accessibility. So I think that I'm trying to get involved with that kind of structure in the future. But I will always be a family doctor. I will always be an obesity doctor. And
Love it.
I'll always be very active, I think, in my community. And I live outside of DC, and it's very easy to be in touch with both the federal and state government. So I know I'll always be doing something like that.
It's amazing. That's amazing. I've said this several times now on this podcast is that the DPC and concierge model, I think that it's necessary for physicians to explore this.
Mm.
Now, is it going to lead to some short-term problems? It is, because them leaving the traditional system once again is going to lead a gap in the care that we need and the providers that we need. But at this point, our system needs innovation and it needs change.
Mhm.
There's going to be turbulence along the way with that. And we have to accept that it might get a little bit worse before it gets better, but searching for these solutions that where we can provide equitable, high quality care is essential. And so I totally respect you for kind of look at these things and look towards the future.
Yeah.
Now, one thing I want to talk about before we go is that you are originally from Sweden. Is that right?
Yeah, I'm from
Mm.
Sweden.
Okay.
Yep.
And I know we talked about this a little bit on our pre-call, but you have family members that have been over there that have accessed a universal style health system.
Yes.
What have their reports been of it?
So universal healthcare increases accessibility to services because of obviously eliminating cost. The things that it did, that's not to say that universal healthcare is perfect in Europe, because it's not. The administrative challenge with universal healthcare is real. The waiting times, as well as in Canada or Europe, the waiting times in the emergency rooms can be a bit longer. The the primary care doctor that you have isn't necessarily one that, or the doctor that you have in general isn't necessarily the one that you chose. It's just the one that is in your area or part of that hospital system that you where you live. With all things said, if your family member breaks their leg, you don't have to worry about, "Oh, how do I get to an orthopedic surgeon, and how much is that gonna cost? And are they gonna cover rehabilitation and PT?" And you don't have to worry about those things because that's not even part of the conversation, that's not a question. Yes, it's covered. And I think that there are positives and there are negatives, but I feel that there are more positives, and I feel better about my family members having universal healthcare compared to if they all lived in the United States and, "Oh, does my I wonder what health insurance my aunt has," or wondering, "Oh, I heard that my grandma's diabetes medication, wasn't covered this month, but it's been covered for the past 6 months. Why is that?" "Oh, my mom who actually lives in the US, her health insurance company just tried to charge her $3,000 for a preventive colonoscopy," which is not okay. It's called the Affordable Care Act and preventive health. It's all should be covered by insurance. And why is that denial even happening for a preventive colonoscopy? So those things don't arise over there. So yeah,
I wonder what it's going to take because I don't foresee the US being in the capitalist system that we live in ever transitioning to a fully universal model.
I don't
Uh,
either.
so I
I,
wonder what is that ideal system and what does that look like for us here?
I think it's going to be incredibly a hybrid system of lots of different options, and it's gonna be, I think, hard to navigate for people in the beginning when you type into, let's say, Google, and you just say, "Primary care doctor close to me," and I'm the one that pops up closest to them, but I'm a DPC, so I don't know. Let's say the membership is $100 a month. You get to unlimited visits for 100 a month, which is pretty standard. But that person can get their labs done with me, imaging done with me at reduced pricing and cost because have a relationship with a local lab, relationship with a local imaging center. But God forbid this patient is in a car crash and goes to the emergency room. They need health insurance regardless. And so you have to explain to a patient, yes, I have a membership fee. I don't handle anything with your insurance, but we keep things prices low, actually, probably lower than what your insurance might be charging you. I'm not gonna be charging you a deductible every time you come in all year, but you're still gonna need health insurance, and you're still not gonna have to pay for that separately just in case something else happens. That's gonna be it's hard to explain to people, and it feels redundant. You wish that there was more of a streamlined system, such as universal healthcare, but I think that the America is a free market, and so is its healthcare.
For sure.
Yeah.
It's going to be a crazy road to see. It's going to be a good one to follow. I can already feel the passion that you have towards it beyond just giving really good care, but really advocating for your patients and for the overall system. I just want to thank you for continuing to put information out there, doing things like coming on this podcast, because we need more things like this and people like you that are willing to put their name out there and share their real life experiences. So, if someone's listening to this and they want to learn more about you and see about your journey, where's the best place to go?
You can find me on social media, on Instagram at Dr. Kazarian and TikTok as well. Yeah, see you there.
Awesome. Awesome. And then last thing is here is if a any sort of healthcare provider is thinking about starting to create content, get their name out there, where do you want them to start?
I want you to start on Instagram and TikTok.
And
That's where
just
I want you to start. Just create an account, a handle with, your nothing too complicated, just your name, your credentials. All you need is an iPhone, use the back camera, get a ring light. You don't need a microphone, but if you want one, doesn't it helps. And just decide from day one, what is your message? What are your videos going to be about? They can be about you. Incorporate yourself as a doctor, as a healthcare professional, but there needs to be something larger going on. People want to be learning, people want to be inspired.
amazing. Dr. Kazarian, I so appreciate you coming on. Like, this has been a lot of fun. I know a lot of people are going to get a lot of value from it.
Amazing. Thank you so much for having me. This was great.
Of course. Awesome. So if you are a healthcare provider, if you're a doctor, PA, NP, PT that's trying to put good quality education out there, has a story to share, just like Dr. Kazarian, please reach out to us, medstorymedia.com/podcast, and we'd love to share your story. We'll see you in the next one.